Regular pain medication use for chronic office-related musculoskeletal pain creates tolerance, dependence, and potentially serious side effects, while the underlying ergonomic and postural problems persist unchanged. You're masking symptoms rather than addressing causes, and that masking comes with significant health risks. Let's examine medication limitations honestly. NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen and naproxen, reduce inflammation and provide pain relief. They work well for acute injuries, but they don't correct your posture or fix your ergonomics. Taking ibuprofen daily while continuing to sit in forward head posture just allows you to continue harmful behaviors without the pain signal warning you. Acetaminophen, Tylenol, provides pain relief but has minimal anti-inflammatory effect, so it's doing even less to address tissue problems. Muscle relaxants cause sedation and cognitive impairment while not addressing what's causing muscle tension in the first place. Problematic patterns emerge when medication becomes chronic rather than short-term. Daily medication use for a chronic condition indicates treatment failure, not treatment success. If you need medication every single day to function at work, your treatment plan isn't working, you're just suppressing symptoms. Escalating doses suggest tolerance development where the same dose provides less relief over time, requiring increases to maintain effect. And medication overuse headaches develop from frequent pain medication use, creating a vicious cycle where the treatment causes additional pain. Risks increase with regular use. NSAIDs cause gastrointestinal bleeding, serious ulcers, and bleeding events, especially with prolonged use or in older adults. They increase cardiovascular risk, including heart attack and stroke, particularly at higher doses. Acetaminophen causes liver toxicity with regular use, especially if you consume alcohol or have existing liver problems. The maximum daily dose is lower than many people realize, and combination products, cold medicines, headache formulas often contain acetaminophen, creating risk of accidental overdose. Opioids for chronic musculoskeletal pain deserve special mention. There is minimal evidence supporting opioid effectiveness for chronic non-cancer pain and substantial evidence of harm, including dependence, overdose risk, and worsened function. Guidelines now explicitly recommend against opioids for chronic musculoskeletal pain, yet they're still sometimes prescribed, creating dangerous situations for patients. Appropriate medication use treats acute flares while you implement ergonomic corrections. You've strained your neck, inflammation is present. A few days of NSAIDs while you rest and correct your workspace setup makes sense. Medication as an adjunct to physical therapy, not a substitute. You take pain medication so you can participate in exercises without excessive discomfort, but the exercises are the actual treatment. And tapering as underlying problems resolve rather than indefinite daily use. Non-pharmaceutical pain management offers alternatives. Ice application during acute inflammation reduces swelling without systemic medication effects. Heat for muscle tension and chronic pain increases blood flow and promotes relaxation. Topical analgesics like creams and gels provide some pain relief with limited systemic absorption and fewer side effects than oral medications. CBD and cannabis for pain management represents evolving territory. Research is limited but growing, with some evidence for certain pain conditions. Legal status varies by location, creating access issues. Quality and dosing standardization problems plague the CBD market. If considering these options, work with knowledgeable healthcare providers and understand this is still experimental treatment for many conditions. The healthcare system incentive problem perpetuates medication over-reliance. 15-minute appointment slots favor writing prescriptions over time-intensive behavioral and ergonomic counseling. Insurance readily covers generic NSAIDs and muscle relaxants, but creates barriers to physical therapy authorization. From a billing perspective, prescribing is efficient. Comprehensive pain management is not. This system pushes doctors toward medication solutions even when non-pharmaceutical approaches would be more effective. For individuals caught in daily medication cycles for chronic office pain, reassessment is necessary. Are you using medication to avoid addressing workspace problems? Is the medication actually helping or just slightly dulling pain while side effects accumulate? What would happen if you aggressively addressed ergonomics while tapering medication under medical supervision? Medication has a place in comprehensive pain management, but it's a supporting role, not the leading intervention. If medication is your primary or only treatment for chronic office-related pain, your treatment plan is inadequate. Address the underlying mechanical and postural causes, use medications strategically for acute exacerbations, and work toward not needing daily medication to function at your job. That's successful treatment, not indefinite pharmaceutical dependence that masks problems while creating new health risks.